Good morning, dear students. Our topic for today is management of patient with airway obstruction. And we'll discuss asthma, COPD, and asthma-COPD overlap syndrome. Background to diagnosing asthma and COPD. Once infectious disease and non-pulmonary conditions have been excluded, the most likely chronic airway disease in children and young adults is asthma. In adults, usually after the age of 40 years, COPD becomes more common and distinguished asthma with chronic airflow limitation from COPD becomes problematic, particularly among smokers. So asthma is disease for young age. For more old age, especially after 40, it can be both asthma and COPD and can be also uh, overlap syndrome, which include both these diseases. Now you see a picture. I tried to show you how does look like typical patient with asthma. As a rule, it is young patient. And for patient with COPD, mostly it is elderly patient who smoke for many years. And due to this chronic illness, due to his age, he feel not well all the time. Patients with asthma have problems with breathing, mostly during attack. Definitions. Asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity, together with variable expiratory airflow limitation. COPD is a common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation that are due to airway and alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. COPD also may be punctuated by periods of acute worsening of respiratory symptoms, called exacerbation. But these periods last usually during days, and periods of asthma exacerbation last few minutes during attack, up to 20 minutes, 1 hour, like this. So both these diseases characterized by airflow obstruction. But in case of asthma, it is mostly reversible. In case of COPD, as a rule, it is chronic. It is chronic, constant, and slowly progressive disease. Why this disease more commonly lead to respiratory failure. But really, this disease is preventable and treatable to prevent and to treat properly respiratory failure. Asthma is more dangerous usually during attack, and in case of attack, patient also can die due to acute respiratory failure. Main symptoms of both disease are shortness of breath, wheezing, and cough. But in asthma it is acute, in COPD chronic, mostly after exercise or morning smoker's cough. Asthma COPD overlap, or ACO, is characterized by persistent airflow limitation with several features usually associated with asthma and several with COPD. ACO does not refer to a single disease entity, but as for asthma and COPD, it likely includes several different phenotypes caused by different underlying mechanisms. Especially in chronic smokers, may be attacks of asthma because COPD is risk factors of asthma development even in more old age, in advanced age, not in childhood. So in this case, patient with chronic dyspnea can suffer from sudden attack of dyspnea also after the contact of allergen. And as a rule, this combination is more severe than single disease. Concurrent doctor diagnosis asthma and COPD has been reported in 15-20% of patients with bronchial obstruction. So it is not so rare. Around 1/5 of all patient population with bronchial obstruction has both asthma and COPD. Patients with features of both asthma and COPD experience frequent exacerbation, have poor quality of life, and more rapid decline in lung function and higher mortality than asthma or COPD alone. We'll discuss treatment later, but even now I want to tell you this problem is common, but there are no specific treatment for asthma COPD overlap. Mostly we use the same drug for asthma and for COPD, and many groups of these drugs are common for both these diseases. And now it is like our lecture plan. Stepwise approach to diagnosis of patient with respiratory symptoms. We'll go in our lecture step by step. Step 1 will include answer to the question, does the patient have chronic airway disease? Step 2, the syndromic diagnosis of asthma and COPD in an adult patient. Step 3, spirometry. Step 4, Cummins initial therapy. And step 5, referral for specialized investigations if necessary. Really, before this year, you must discuss separate asthma and separate COPD. But in real life, mostly you have to do differential diagnosis. So we start with chronic airway disease, complaints and typical features. Then to distinguish this disease, to make proper diagnosis, and very important for both this disease, method like spirometry. It is main method to confirm bronchial obstruction and to differentiate is it reversible or irreversible. Of course, we have to speak about therapy of this disease, and also in case of when you are not sure in your diagnosis, you have to refer to specialized investigations and to specialized centers. Except spirometry and simple analysis, you have to do more advanced analysis. Step 1, clinical history. You have to check history of chronic recurrent cough, sputum production, dyspnea or wheezing, or repeated acute lower respiratory tract infection. So main clinical features, I again repeat to you, recurrent cough, sputum production, maybe dry cough, dyspnea or wheezing. And also bronchial obstruction disease more commonly complicated by respiratory tract infection than these persons suffer from respiratory tract infection more common than healthy persons. Report of a previous doctor diagnosis of asthma or COPD. If you see a patient first time, it doesn't mean that he comes to you first. Maybe he visited other doctors, and of course you have to check all his visits and all document. History of prior treatment with inhaler medications. Mostly medication for bronchial obstructive syndrome are inhaler medication, which act focally and are more effective. So patient may not remember the name of medicine, but he use or not use inhaler, he may answer to this question. History of smoking tobacco or other substances, very important for COPD diagnosis. Exposure to environmental hazard, occupational or domestic exposure to airborne pollutants may be important for both COPD and for asthma. Lung growth and development. It is slightly new way to confirm diagnosis of bronchial obstruction. Now we know that low birth weight, frequent childhood respiratory infection may lead to this chronic disease, asthma or COPD. So if patient know, you have to ask him about birth weight and frequency of respiratory infection in childhood. And also it is proved that low socioeconomic status consistently associated with airflow obstruction. not proper living condition, more commonly lead to different disease and especially respiratory disease, mostly due to pollutant, due to not healthy lifestyle. Next one, which included step 1, is physical examination. It can be normal, especially in patients with asthma. Without attack may be normal vesicular breathing and no complaints. All symptoms develops during attack. Evidence of hyperinflation and other features of chronic lung disease or respiratory insufficiency. More typical for COPD, which is combination of chronic bronchitis and emphysema. So emphysema gives history of hyperinflation. But asthma, severe asthma, also lead to chronic bronchial obstruction and is accompanied by emphysema. So emphysema more typical for COPD, but you can't exclude asthma in this case also. And in both cases, you may find abnormal auscultation with or crackles or together. And in COPD, it is most common. It is prolonged all the time, especially in moderate to severe situation. But in asthma, it may be absent, but always present during attack. X-ray examination is obligatory in case of chronic cough. It may be normal, particularly in early stage, and in asthma even in more advanced stage. Abnormalities on chest X-ray or CT scan performed for other reasons such as screening for lung cancer, including hyperinflation, air wall thickening, air trapping, bulla, or other features of emphysema. So X-ray shows us not bronchial obstruction. It shows us only features of emphysema. That's why it is not first-line method for diagnosis of bronchial obstruction. But we have to do it, first of all, to exclude other reasons of chronic cough. Maybe not only overlap of COPD and asthma. Patient may suffer, for example, from tuberculosis together with asthma. So you have to rule out other disease, accompanied disease, or to make differential diagnosis. X-ray also may identify an alternative diagnosis, including bronchiectasis, evidence of lung infection such as tuberculosis, interstitial lung disease, or cardiac failure. So, for differential diagnosis. And now I show you two X-ray. From the left side, X-ray in patient with COPD, and from the right side, X-ray for patient with asthma. In case of asthma, it looks normal. In case of COPD, you can see hyperinflation. You will see lung pattern is less obvious compared with lung pattern in asthma. And belly chest you can see, horizontal ribs and big intercostal space compared with asthma X-ray. And you see lung are enlarged in size compared with normal X-ray. Now let us go to step 2, to differentiate asthma, COPD, and ACO. Past history or family history. In asthma, many patients have allergies and a personal history of asthma in childhood and family history of asthma. So asthma started earlier. So if you are adult doctor, if you see adult patient, you have to discuss past history. In case of COPD, history of exposure to noxious particles and gases, mainly tobacco smoking and biomass fuels. Also, it is most common. Tobacco smoking may be 95% of all COPD reasons, but rare can be genetic factors which leads mostly to emphysema development. In COPD, emphysema usually mostly develops like complication of bronchial obstruction due to difficult to exhale air. It will lead to increased pressure inside alveolus and its enlargement and rupture of septum of alveolus. but maybe emphysema alone without bronchial obstruction, especially if there are some genetic problems. We know for a long period of time that deficiency of alpha-1 antitrypsin may lead to emphysema. And now scientists found that elevation of matrix metalloproteinase also can cause emphysema. Reason for it, both enzymes which lead to destruction of interstitial tissue may lead to rupture of wall of the alveolus, and it can cause bull formation and emphysema development. Past history for ACO. Frequently a history of doctor-diagnosed asthma, current or previous, because it starts in childhood as a rule. Allergies and a family history of asthma and or history of noxious exposure. So together, asthma history and long-lasting smoking. Age of onset, I already told you, but let us repeat it. Asthma, usually childhood, but can commence at any age. Yes, it can start. It is usually childhood, but not obligatory. And there is even special population, a special subgroup of asthma, which called asthma with onset in the advanced age. It can be. You can't exclude asthma even in elderly persons. COPD usually starts at the age of more than 40 years old. But COPD is developed in patient who is chronic smoker, but not all chronic smokers develops COPD. Of course, genetic predisposition plays very important role. Usually, even one-fifth of smokers, even after 40, develops COPD, fortunately. Not all. But unfortunately, some persons are high sensitive to this tobacco smoke and they can develop COPD even in young age. Dear students, if you are current smokers, don't think that you will be healthy all the time. After 40, you have very high risk. And even now, some of you who overuse smoking may develop features of COPD even at age 20 or 30. ACO, we are speaking about most typical picture, but can be everything in real life. In asthma COPD overlap, usually age over 40, because two diseases together may develop when they can both develops, and COPD develops mostly after 40. So ACO also after 40, but may have had symptoms in childhood or early adulthood. Comorbidities. Asthma may be risk factors for the development of chronic airflow limitation and COPD. So asthma can cause COPD. COPD more frequently in patients with asthma than in healthy patients. If there are some problems in airflow, it means that it can cause different disease. Concomitant chronic disease occur frequently in COPD patients, and this disease include cardiovascular disease, skeletal muscle dysfunction, metabolic syndrome, osteoporosis, depression, anxiety, lung cancer. So COPD is chronic oxygen insufficiency. So it can cause problems in different organs and systems. It can lead to ischemia of the heart, this ischemia of the muscles. Also, it can lead to ischemia of the brain. It is not stroke, but maybe some mood disturbances like depression, anxiety. And chronic smoking, it is a cancerogen, so can be lung cancer in patients who smoke for a long time. Pattern of respiratory symptoms. In case of asthma, symptoms may vary over time, day to day or over a longer period. Most important to differentiate asthma and COPD, vary over time, often limiting activity. but not always. In intermittent asthma, a person can be even sportsman. In more advanced case, it limiting activity. Symptoms in asthma often triggered by dust or exposure to allergen, sometimes by emotion, rare by exercise. So mostly patient knows when he have attack, not always. But if a patient is clever and pay attention, he knows that when there are flowers will be attacks of asthma, or when he see cat, it may lead to attack of asthma. But not always it is so obvious, especially if there is not only single allergen which cause asthma attack, maybe multiple allergens. And in this case, even clever persons cannot understand what can lead to asthma attack. But also, no, how to differentiate asthma and COPD? Mostly in COPD, attack of dyspnea caused by exercise, and in asthma at rest, but can be exercise-induced asthma. In real life, very difficult to differentiate, but exercise-induced asthma is rare situation, mostly asthma attacks at rest. In case of COPD, the most common respiratory symptoms include dyspnea, cough, or sputum production. Chronic, usually continuous symptoms, particularly during exercise, with better and worse days. COPD also can vary, but mostly it is stable. It can vary mostly by more frequent smoking or by infection. If patients with COPD get acute bronchitis, of course it will affect cause of underlying disease, affect severity of COPD. In case of ACO, respiratory symptoms, including exertional dyspnea, are persistent, but variability may be prominent. So, dyspnea during exertion, like in COPD, but sometimes it increases very significantly and suddenly without exertion. And it means that it is also a bronchospasm due to allergens. So, in case of ACO, symptoms include both asthma and COPD, and very difficult to differentiate. This diagnosis is not sole diagnosis. Previously, we are speaking only about asthma and about separately about COPD, but with time it becomes clear that very difficult in some persons, 1/5 of persons, to differentiate what is it, because both are present. So for this situation, not with higher level scientists create new diagnosis and call it asthma COPD overlap syndrome. Time course and exacerbation, what is typical for each disease. In case of asthma, often improves spontaneously or with treatment, but sometimes may result in fixed airflow limitation. Exacerbations occur, but the risk of exacerbation can be considerably reduced by treatment. So often improve spontaneously or with short-acting bronchodilators inhalation. In severe cases, not improve completely. And treatment give positive effect in both situations, acute exacerbation and chronic dyspnea. COPD, generally slow progressive over years despite treatment. Exacerbation can be reduced by treatment if present comorbidities contribute to impairment. So COPD is slowly and looks not dangerous, but in when year passed, it is irreversible even with proper treatment, because there are emphysema, sclerosing changes in the lung tissue, and it is irreversible and will lead to severe respiratory failure. ACO symptoms are partially but significantly reduced by treatment. Exacerbation may be more common than in COPD, but are reduced by treatment. Comorbidities can contribute to impairment. Progression is usual, and treatment needs are high. So, ACO have more severe clinical course, more faster progression, and more poor prognosis. Lung function in asthma may be normal between symptoms, normal breathing, current or historical variable airflow limitation, bronchodilators reversibility. So lung function changes very significantly. COPD, persistent airflow limitation. FEV1 may be improved by therapy, but post-bronchodilators ratio of FEV1 to FVC less than 0.7 persists. We'll discuss in few minutes spirogram, but you have to remember even from now that ratio of FEV1 to FVC should be less 0.7 or less than 70%. It is very important for diagnosis of COPD because airflow obstruction is constant. In case of ACO, persistent airflow limitation. Airflow limitation not fully reversible, but often with current or historical variability. Diagnostics. In asthma, chest X-ray usually normal. In sputum, blood and airway may be eosinophils and neutrophils. In COPD, chest X-ray, severe hyperinflation in severe cases, or other changes of COPD. Neutrophils in sputum, lymphocytes in airway may have systemic inflammation. So both has inflammatory properties, and for asthma more typical eosinophils, allergic inflammation. ACO, chest X-ray similar to COPD, eosinophils and neutrophils in sputum. So ACO combine both these situations, hyperinflation in X-ray and eosinophils in sputum or blood. Oximetry and arterial blood gas measurement. Pulse oximetry can be used to evaluate a patient's arterial oxygen saturation and need for supplemental oxygen therapy. Pulse oximetry should be used to assess all patients with clinical signs suggestive of respiratory failure or right heart failure. If peripheral arterial oxygen saturation is less than 92%, arterial or capillary blood gases should be assessed. Especially COPD lead to respiratory failure. That's why we have to check oxygenation of the blood for decision about oxygen supplement in this patient. And now you can see a table for differential diagnosis of asthma and COPD. We already discussed all items. Here I only combined in one table for more clear and more obvious differential diagnosis. And now we'll go to step 3, which calls spirometry. Most important diagnosis for bronchial obstruction. Spirometry is essential for the assessment of patients with suspected chronic disease of the airways in order to confirm or exclude the diagnosis. Here you can see lung volumes, tidal volume, vital capacity, which include inspiratory capacity and also expiratory reserve volume. And it includes vital capacity really is a sum of tidal volume, inspiratory reserve volume, and expiratory reserve volume. And also in the lungs present residual volume, which persons cannot exhale. All these volumes are calculated during spirometry test. How to perform spirometry? I will tell you a few words how to do it. Patient have to take tube in his mouth and doctor or nurse have to ask patient to make full inhalation and to make fast and forced exhalation. For bronchial obstruction, very important forced exhalation, more important exhalation than inhalation, because obstruction mostly affect exhalation, and very important to do it forcefully, because if patient do it slowly, it will not reveal bronchial obstruction. And main values which are important. There are many values, but especially for students, you have to remember two main values, FEV1 and FVC. Forced expiratory volume in first second of exhalation and forced vital capacity. So all airs which patient can exhale, it is forced vital capacity during forced exhalation, and air which is exhaled during first second. FEV1 should be more than 80%. All values should be more than 80% in healthy person. But ratio of FEV1 to FVC, which is very important, especially for diagnosis of COPD, in normal situation should be more than 70% or 0.7. As a rule, FEV1 is more significantly low in COPD compared with asthma. Because asthma, we do spirogram not during attack. During attack, FEV1 will be very, very low, even less than in case of COPD. But usually we perform spirometry in patients without attack. In this case, bronchs are not constricted at all in mild cases or not constrict significantly. That's why FEV1 may be near normal value. In case of COPD, chronic obstruction, and it is FEV1 decreased significantly. The same like FVC. In case of asthma, FVC not affected too much. Spirometry is required to make the diagnosis of COPD. The presence of bronchodilators FEV1 to FVC less than 0.7 confirms the presence of persistent airflow limitation. It means it confirms the diagnosis of COPD. But you have to remember that you should do it after bronchodilators, to check it after inhalation of bronchodilators for more correct assessment of this ratio. The goals of COPD assessment are to determine the level of airflow limitation by spirometry, the impact of disease on the patient's health status, and the risk of future events such as exacerbation, hospital admission, or death in order to guide therapy. So even now, when we discuss spirometry, I want to tell you a few words about classification, new classification of COPD. This new classification include old COPD classification, we'll discuss it in a few minutes, and also include risk of future events such as exacerbation, hospital admission, or death. Now we understood that we have to treat patient at this moment and to protect him for future, to give proper treatment for prophylaxis of disease progression. So now we use not only spirometry and clinical symptoms, we use data to differentiate high or low risk of exacerbation. And now I want to show you how does the spirometry looks like. I show you curve, flow volume curve and liter volume time curve. FEV1 is very clearly visible in volume time curve. Here you see high amplitude of the curve and short duration of exhalation. In case of exhalation, the curve goes up. In case of inhalation, it goes down. You see, in this curve, exhalation lasts around 2 seconds. Normal time for exhalation is 1.5 to 2 seconds. And more than 80% is exhaled during first second of exhalation. FEV1 more than 80%. In case of bronchial obstruction, which you see in this case, the amplitude of this curve decreased because very significant obstruction and patient cannot exhale as much as possible, especially if this patient suffer from emphysema also. And time for exhalation increase also. Here you see exhalation lasts not 2 seconds, it lasts more than 4 seconds. To check properly ratio of FEV1 to FVC and also to differentiate asthma and COPD, doctors have to do test with bronchodilators. Mostly use salbutamol, short-acting bronchodilators. And in this situation, first of all, patients shouldn't use any medicine before. At least the long-acting medicine, bronchodilators, he shouldn't use at least 1 day before. Then he come to the doctor and firstly do exhalation without any medicine. We measure and keep the data in the computer. Then you ask patient to inhale salbutamol and wait for 10-15 minutes when salbutamol effect develops. And after it, you ask patient to exhale again. If after exhalation patient breathing improved, it suggests mostly about asthma, if it improved significantly. The level of significance is 12%. If FEV1, main value is FEV1, improves more than 12%, it confirms diagnosis of asthma. But based only on spirometry data, we can't give diagnosis. Diagnosis is made when you have combination of clinical symptoms, analysis, and spirometry. So conclusion in spirometry will be if FEV1 improved more than 12%, that broncho obstruction is reversible. If FEV1 improves, for example, 10%, it is less than 12, it means that bronchial obstruction is irreversible and more typical for COPD. But if it is from 10 to 14%, from 10 to 12%, it's under question near the borderline, and as a rule, it is ACO. Now we'll discuss which changes may be in all cases. If normal FEV1 to FVC ratio pre or post bronchodilators, it may be in asthma. It cannot be in COPD. FEV1 FVC ratio for COPD always should be low. And in ACO, it also cannot be because ACO have to include COPD. Normal ratio, only asthma. From these three diseases. Also, it can be in other disease. We have many lung disease except these three. If post-bronchodilators FEV1 to FVC ratio is less than 0.7 or less than 70%, in case of asthma, it indicates airflow limitation but may improve spontaneously or on treatment. In COPD, it is required for diagnosis. In an ICO, it's usually present. So in asthma, can be less than 0.7, can be more, can be all. In COPD, always less than 0.7, and for ACO, the same. If post-bronchodilators FEV1 more than 80% of predicted, if FEV1 is normal. Asthma, it can be in case of good asthma control or mild asthma cause in interval between symptoms. In COPD, also can be, it's classified like mild asthma based on the classification. In mild asthma can be. In ACO also can be. If FEV1 less than 80% of predicted. In asthma can be. Risk factor for asthma exacerbation. For asthma, mild to moderate asthma, usually normal FEV1. In more severe asthma, it is decreased. And risk of exacerbation, risk of respiratory failure increase in this patient. In COPD, The level of FEV1 is an indicator of severity of airflow limitation and risk of future events, mortality and COPD exacerbation. Not the same like asthma, but it is constant and even used in classification. ACO, FEV1 less than 80% is indicator of severity of airflow limitation and risk of future events. If bronchodilators FEV1 increase more than 12%, it is typical for asthma. In case of COPD, it is unusual, but it can be in ACO. So, FEV1 increase more than 12% can be in typical for asthma, can be in ACO, not significantly, near 12%, and unusual in COPD. And now let us go to classification of COPD. It is old classification, which I hope every student already know. First of all, in all patients with COPD, I repeat again and again, ratio should be less than 0.7. And we classify it to mild, moderate, severe, and very severe based on FEV1. FEV1 more than 80%, it is mild. From 80 to 50%, it is moderate. 50 to 30, severe, and less than 30 is very severe. Also, we have questionnaire to check clinical symptoms. Level of bronchial obstruction, which we see by spirometry, usually correlate with clinical symptoms. But no, we cannot classify disease without clinical symptoms at all. We have to know something about clinical symptoms. And maybe more simple is MRC dyspnea scale, which includes questions. I'll read you questions and tell the bulk for each of them. First statement. I only get breathless with strenuous exercise. It is normal situation and we don't give any pulse to person. Next statement. I get short of breath with hurrying on level ground or walking up a slight hill. 1 ball. Next, on level ground, I walk slowly than people of my age because of breathlessness, or I have to stop for breath with walking at my own pace on the level. 2 balls. Next, I stop for breath after walking about 100 yards or after a few minutes on level ground. 3 balls. And 4 balls if person is too breathless to leave the house or breathless when dressing and undressing. So we can grade severity of COPD based on the level of dyspnea. And now we use a new classification which called ABCD classification. And in this classification, Group A, low symptom severity, low exacerbation risk. Group B, high symptom severity, low exacerbation risk. Group C, low symptom severity, high exacerbation risk. And Group D, high symptom severity, high exacerbation risk. So now we include in this classification, like I told before, not only symptoms severity, not only spirometric data, also risk of exacerbation. And risk of exacerbation is very important for patient future life, and we have to use it. So first of all, we send person for spirometry. If FEV1 to FVC is less than 0.7, it confirms bronchial obstruction. Then we check FEV level and check is bronchial obstruction mild, moderate, severe, and very severe. And we have to write it in COPD in diagnosis. COPD, moderate severity of the disease. And then we have to check future events and risk exacerbation. How to check the risk? We have to discuss about anamnesis. High risk of exacerbation if patient is uh, hospitalized uh, more than one times in a year previously, and low risk exacerbation if in previous year patient was not hospitalized, it's very low risk of exacerbation. If one times, it's under question. So if frequently hospitalized, it means that previously he have high risk, higher frequency of exacerbation, and in future we think he will have more high risk of exacerbation also. There are other values which may affect risk of exacerbation. Low FEV1 value, for example, also increase risk of exacerbation in future, development of respiratory failure, severe respiratory failure, and even death. And also, to check clinical symptoms, we use scale MMRC, which I already report you, and also present near similar CAT scale or CAT scale, and we calculate both. If in MMRC scale it is 0 or 1 bar in total, it means that clinical picture it is not severe, low symptom severe. If MMRC total score is more than 2, it means that clinical picture is severe, high symptom severity. So it is new classification which include both spirometry data, clinical symptoms, and anamnesis for more accurate assessment of future course of disease and for more accurate treatment. If more high risk, you have to use more medicine for treatment. Now we'll talk about treatment for old patients with chronic airflow limitation. First of all, it includes treatment of modifiable risk factors, including smoking cessation, nicotine replacement, e-cigarette, varenicillin, Champix, bupropion, Ziban. There are examples of drugs for, for smoking, treatment for nicotine replacement. So, better to stop smoking. Treatment of comorbidities. Comorbidities affect clinical course of bronchial obstruction. Physical activity should be done. Patient shouldn't sit even if uh, he has high level of dyspnea. He have to move as much as it possible. He shouldn't stop. He have to have training. Pulmonary rehabilitation, and in patients with bronchial obstruction are commonly recommended vaccination. Now it is recommended for all population for influenza and pneumococcus. We are speaking about these two methods. We are not speaking now a day about COVID vaccination, but for influenza and pneumococcus, vaccination is obligatory for patients with bronchial obstruction. Appropriate self-management strategies, personal self-management strategies have to be made by patient and doctor. Regular follow-up and inhaled techniques. Inhaled techniques are very important. It Now many specialists pay attention to inhaler techniques, because if patient don't use inhaler properly, it means that he doesn't receive all drug. He use the drug not in prescribed dose or not use drug at all. In this case, patients should to inhale during deep inhalation and puff and press the button when he start inhalation. Then he have to hold breathing. All medicine have to be inside, and then slowly exhale through the nose. And nothing should go away from his mouth. All medicine and as much medicine as it possible should go inside the lung and be there. To reach more distant part of the lungs, we have to use more small particles. So different inhalers have different cost. More expensive inhaler usually make smaller particles, which can reach distal bronchioles easily compared with bigger inhalers. Now you see metered dose inhaler with bigger particles and soft mist inhaler with smaller particles. Especially in asthma attack, you have to use smaller particles. You have to use nebulizer. We did it very smaller, and they can pass through very small orifice of the bronchial tree during bronchial constriction. Also can be microdose dry powder inhaler. They are automatic and also more expensive but more new and more comfortable for patient. And health patient don't make mistake. Health patient not increase the dose, not decrease the dose. It is done automatically. Proper dose is inhaled. And treatment for stable COPD depends on group, which I told you A, B, C, and D. In group A, low frequency severity, low exacerbation exacerbation risk. You have to use single short or long-acting anticholinergic or beta-2 agonist. Escalate to alternative class of bronchodilators if necessary. So possible to use it not regularly, mostly during exacerbation if patient don't suffer from dyspnea, and in any situation it should be only one group of medicine, not in mild to moderate dose. In group B, high symptom severity. In this case, of course, you have to increase the level of treatment, but exacerbation risk is low. That's why you shouldn't increase it so much. Start with long-acting muscarinic antagonist, LAMA, or long-acting beta-2 agonist, LABA. Escalate to combine LABA and LAMA. In group A, can be used short-acting single medicine. In group B, always long-acting because symptoms are all the time and you have to treat patient all the time. It should be effective. Medicine should be effective during full day. So long-acting medicine, and very commonly in high symptom severity, it is combination of LAMA and LABA. But you have to remember that LAMA, muscarinic antagonist, it is proved that they are more effective for prophylaxis of exacerbation compared with LABA, beta-2 agonists. So if to start treatment with single long-acting medicine, better to use LAMA than add LABA. For group C, low symptom severity, but exacerbation risk is higher. Start with LAMA, the same, then escalate to LABA-LAMA or even LABA inhaled corticosteroids if exacerbation continue. So inhaled corticosteroids also used in case of COPD. Three main groups for bronchial obstruction are beta-2 agonists, inhaled corticosteroids, and long-acting muscarinic antagonists. All of them may be used in both disease, but in both disease, the same frequency may be of usage for beta-2 agonists because they relax bronchial constriction, they relax muscle spasm, and muscle spasm is important in both situations. But for COPD, preferable group is LAMA, muscarinic antagonists, and for asthma, preferable group is inhaler corticosteroids. You we'll discuss treatment of asthma later. We'll start with inhaled corticosteroids in case of asthma. But even in COPD with high risk of exacerbation, you have to use inhaled corticosteroids. In group D, high risk and high symptoms. You have to start with combination, LABA and LAMBA preferable, and it may escalate to three groups combination, LABA, LAMA, and inhaled corticosteroid. Also can be added roflumilast And in case of inflammation, if you suspect that there is infection, you may use antibiotics, uh, mostly macrolide. And it is not alone, but in combination with LABA/LAMA inhaled corticosteroids. In patients with stable COPD and moderate desaturation, long-term oxygen treatment should not be prescribed routinely. In patients with severe chronic hypercapnia and a history of acute respiratory failure, long-term non-invasive ventilation may decrease mortality. So oxygen therapy is recommended mostly in severe COPD. In select patients with advanced emphysema, surgical or bronchoscopic interventional treatment may be beneficial. So, in case of severe emphysema, very severe dyspnea, when patient cannot move even in his own room due to dyspnea, when he is all the time blue and cannot do anything, main treatment is lung transplantation. And of course, before lung transplantation, chronic oxygen therapy. And I want to remind you medications, anticholinergics. I will read only list you which medications are under these groups. Short-acting muscarinic antagonist. Ipratropium bromide may be most famous, and oxytropium bromide. Long-acting muscarinic antagonist. Tiotropium bromide and MONU, mostly students don't know it, aclidinium bromide, umeclidinium bromide, and glycopyrronium bromide. So tiotropium, aclidinium, umeclidinium, and glycopyrronium. Beta-2 agonists, short-acting, phenytoterol, salbutamol most famous, and terbutaline, MONU. Long-acting, formoterol. Formoterol is very interesting drug which may be mostly classified like long-acting, but in some classification like short-acting, because like short-acting, it starts its action very fast, but it continues its action for a long period of time. So this drug is very good and now very commonly recommended in treatment of asthma. We'll discuss it later. So long-acting beta-2 agonists, formoterol, salmeterol, and MONU, indacaterol, and vilanterol. Now I give you examples of this medication and how do they look like. More cheaper and more old medication are ipratropium bromide and tiotropium bromide. One of the company names of ipratropium bromide is Atravent, and tiotropium bromide Spiriva. And you see here, it is not so comfortable, more easy, more cheaper inhaler, which use capsule or patient's puffing and not always correct dose, more forces of patient. That's why more commonly leads to mistake in dosage and in inhaler techniques. And for beta-2 agonist, also old, salbutamol, one of the common company name is Ventolin, and salmeterol, Serivent. Also can be combination of beta-2 agonist and anticholinergic. I told you that in stage B and especially C, always combination of beta-2 agonist and anticholinergic. Most common combinations are phenytoterol, ipratropium, short-acting, and salbutamol, ipratropium can be used when present exacerbation. More commonly used, long-acting beta-2 agonists and anticholinergic inhaler. And these are MONU and call indacaterol, glycopyrronium, vilanterol, umeclidinum. Also available and cheap are methylxanthines, aminophylline and theophylline. They can be used, but they are not recommended so commonly because they have many side effects, especially most dangerous effect to the heart, I told you that in COPD, very commonly due to hypoxia is cardiovascular problems. And also, aminophylline and theophylline leads to smooth muscle relaxation. They relax smooth muscles also in peripheral arterioles. It can lead to drop of blood pressure, and also it can cause Stolen syndrome in if present obstruction of coronary artery and can cause angina attack, and also it can cause tachycardia. Not in all patients, of course. So if patient is poor and cannot buy more new drugs, you may recommend it to treat COPD for prophylaxis of progression. But they are not first-line drugs. They are old. And one new drug is phosphodiesterase 4 inhibitors, which is recommended in patients with severe to very severe COPD, and it's called roflumilast, used in tablets, not in inhalation. One of the combination of ipratropium phenytoterol, it is old and famous, and it called Veradual. Mon-U combination of Mod-U drug, umeclidinum plus vilanterol, also anticholinergic plus beta-2 agonists, called Anoro. And roflumilast company name is Daxas, used in tablets. Can be combinations of LABA plus inhaler corticosteroids in one inhalers, which is more effective than the individual components in improving lung function and health status in patients with moderate to very severe COPD. Can be combination of formoterol plus budesonide, salmeterol plus fluticasone. Budesonide, fluticasone are inhaled corticosteroids. Vilanterol plus fluticasone. But it is combination. In COPD, inhaled corticosteroid not used alone, only in combination. And we try to avoid inhaled corticosteroid in non-severe cases because long-term use of systemic corticosteroid and inhaled corticosteroid can lead to side effects. Inhaled corticosteroids, first of all, increase the risk of pneumonia. And systemic oral corticosteroids, which may be recommended in very severe cases of overlap syndrome or of asthma, can lead to numerous side effects, which include diabetes mellitus, osteoporosis and fracture, depression, hypertension, and many other side effects. But no, if nothing helps, oral corticosteroids are very powerful, but lead to many side effects. Так, fluticasone plus viranterol in one inhaler, one of the company name is Relvaral, Ellipta. Budesonide plus formoterol is Symbicort. Try to remember this name because budesonide plus formoterol is most commonly recommended drug for treatment of asthma. So formoterol plus inhaled corticosteroid. Most cheap, most available is Symbicort. Other COPD medication may include, they are not first line but can be used, mucolytics and antioxidant, which may reduce the risk of exacerbation in select population, not for effective. Antibiotics, it can be used mostly if patients suffer from acute tracheobronchial infection. Long-term azithromycin and erythromycin therapy reduce exacerbation over 1 year. Possible to use it for a long period of time. But this treatment is associated with an increased evidence of bacterial resistance. Other anti-inflammatory agents are discussed because chronic inflammation, play a role in the development of COPD, and we try to find new anti-inflammatory drugs. And it can be leukotriene modifiers, but now they are not confirmed for COPD patients. Anti-tumor necrotic factor antibody has no evidence of benefit in patients with moderate to severe COPD. And statins also has anti-inflammatory effect. And if patient has combination of cardiovascular disease and bronchial obstruction, scientists try to use simvastatin like anti-inflammatory agents, but it doesn't prevent exacerbation in COPD patient. Now, I feel you are tired. Let us have 5 minutes for break, and then we'll finish our lecture and we'll discuss a treatment of asthma. I want you to differentiate both this treatment, so let us have 5 minutes for break. Okay, now let us continue and we'll discuss asthma treatment. Few decades ago, in previous century, we are afraid of asthma very much. We think that it is very dangerous disease, but now treatment of asthma improves very significantly. And patient with asthma may be even a sportsman, may live like a healthy patient if he start treatment earlier and have good symptoms control. And we have control-based asthma management cycle, which include assess of asthma severity to make proper diagnosis and assess of asthma severity, which include symptoms, risk factors, inhaler techniques also are important for assessment, for proper treatment, for future effect of treatment. And we have to discuss with patient preference. We have to assess it everything. Then adjust treatment, which include, first of all, asthma medication, but not only them, or non-pharmacological strategies and modifiable risk factors. If patient has only single allergen or dual allergens, you have to improve patient from harmful condition to recommend patient to avoid contact with allergen if it is possible, to change the living place, uh, don't to change working place. Of course, it's not very comfortable for patient, but possible. And in some situation, patient became absolutely healthy person and not need treatment anymore. So, if patient mostly treated, should be treated, you have to adjust pharmacological treatment. And then you have to review response, symptoms, exacerbation, side effect, patient satisfaction, and lung function. You have to check asthma symptoms control. If not proper, you have to add something, and if proper, you can continue or even reduce. Doctor have to use the lowest dose of medicine to prevent each side effect. But these lowest dose have to be effective. If they are not effective, we have to increase the dose and even transform inhaler medication to oral. Classification of asthma severity. I started with old classification, which not so commonly recommended nowadays. You know that asthma may be intermittent and persistent. Intermittent asthma, we are speaking about daytime symptoms. It's based on the classification of frequency of attacks. Symptoms fewer than 2 times a week. So very rare symptoms, not frequent. One or less than once a week or less than twice a week. Mild persistent asthma, symptoms more than 2 times a week, but more than once a day. From once a week to once a day. Moderate persistent asthma, symptoms every day, and severe persistent asthma, constant symptoms. We use classification mostly for treatment, for proper treatment. And now we even, not we, scientists even make new classification based on the treatment effect. Mild asthma, well controlled, with as needed reliever medication alone or with low dose inhaled corticosteroids. There are stepwise treatment of asthma, which include 5 steps. As needed reliever medication alone or reliever medication plus low dose inhaled corticosteroids, they are step 1 or step 2. Severe asthma requires higher dose combined treatment of inhaler corticosteroids and long-acting beta-2 agonists, which is step 5, and may be uncontrolled despite this treatment. And all other types we classify like moderate asthma. Usually it is step 3 or 4 treatment, well controlled with low or medium dose of combination of inhaler corticosteroids and LABA. So mild asthma, low dose or only reliever medication, severe all medicine in higher dose, and moderate asthma, all other cases. For safety, one more very important view from 2019 year. For safety, DINA not longer recommends starting with SABA-only treatment. DINA recommends that all adults and adolescents with asthma should receive inhaled corticosteroid-containing controller treatment to reduce their risk of serious exacerbation and to control treatment. Preferable reliever is inhaled corticosteroid formoterol. You know that there are two types of treatment of asthma, reliever and controller. Reliever, it means emergency treatment to relieve asthma attack, to stop symptoms of suddenly onset dyspnea, suddenly increased dyspnea. And controller for prophylaxis of this attack, everyday treatment. And previously, most famous reliever medication was salbutamol. Now we transform salbutamol to formoterol, which has specific properties. It starts as fast as salbutamol, but worked more longer, and it is better because patient is protected against bronchospasm for a longer period of time. Maybe he is still in contact with allergen. So formoterol is the best from beta agonist, and it is in combination with inhaler corticosteroids. Inhaler corticosteroids previously was first-line treatment for prophylaxis, for control treatment, and now it included all this in reliever treatment. Because there are three main mechanisms of bronchial obstruction, which include spasm of muscles, mucus hypersecretion, and inflammation. And in case of asthma, main mechanism is allergic reaction, is inflammation. And in this case, mostly effective in many, 99% of patients effective are corticosteroids. That's why this group of drug is included. Even in reliever medication, in emergency treatment, they don't start action faster. Formoterol and salbutamol started action in 5-10 minutes. Inhaled corticosteroid after 30 minutes. But they affect main mechanism of bronchospasm. So it is very good. They relieve patient's condition completely and protect against next bronchial obstruction. So if we relieve only bronchospasm, dyspnea will decrease, but wall thickening will still be present. And even small tiger may lead to next significant, more severe bronchial obstruction. To protect against this risk, we have to use better to use inhaled corticosteroid formoterol. No, of course, possible to use salbutamol, still possible. It was effective many years, and now it will be effective, but preferable inhaled corticosteroid formoterol. And I again show you this most commonly available drug, which combine budesonide and formoterol in one inhaler, and it called Symbicort. Treatment of asthma include quick reliever medication, which relieve asthma exacerbation. Now it is low dose inhaled corticosteroid formoterol. Formoterol is quick reliever, long acting but quick reliever, and not preferable but famous salbutamol. Next one, long-term medication. Inhaled corticosteroid, long-term controller medication, long-acting beta-2 agonist, and leukotriene receptor antagonist, and other new monoclonal antibodies. And also long-term controller include LAMA. So inhaled corticosteroids, they are preferable. We'll discuss it later. LABA, we already discussed. Now I want to list few leukotriene receptor antagonists, which are zefirlukast, montelukast, pranlukast, and new are created. Monoclonal antibodies against immunoglobulins or pro-inflammatory interleukins, against immunoglobulin E, amalizumab, interleukin 5, which is pro-inflammatory, called reslizumab. And as you know, monoclonal antibodies, so-called biological drugs, are in progression now, and we create more and more antibodies, and more new drugs will develop. And if we are thinking about high role of inflammation in case of asthma, we have to use these drugs. But they are recommended, but they are not first-line treatment. And when we'll discuss treatment, we will pay attention, first of all, to first-line treatment. These more expensive and more new drugs, not the drugs of the initial treatment. If others are not effective, more cheap and more long used, which we know better, you can add leukotriene receptor antagonists on monoclonal antibodies. Or if patient, for example, cannot use LABA, if it lead to some side effect, if patient has bradycardia, significant LABA, mostly for adrenal receptor in the lung, but they can affect heart receptors also, and it can lead to heart block, for example. If LABA are contraindicated, you can use leukotriene receptor antagonist, or if inhaled corticosteroids are contraindicated, if patient has uncontrolled diabetes mellitus, they can cause hyperglycemia. So it is second line of drug. They are good, but not first line drug. And monoclonal antibodies the same. Also can be used LAMA, a long-acting muscarinic antagonist, which include tiotropium, first of all, but they are not preferable group to treat asthma. For COPD, so from these three groups, third place take inhaled corticosteroid. For asthma, LAMA. First line group for COPD is LAMA. First line group for asthma, inhaled corticosteroid, ICS. And here I used few drugs which are under ICS. You have to remember that prednisolone is not inhaled corticosteroid. It is corticosteroid, but oral. Names for inhaled corticosteroid: beclometazone, budesonide, fluticasone, mometazone, triamcinolone, and others. And all of them has low, medium, and high doses. Each of them has different level of this dose. So I only show you this table, but I will not list all the dose for each medicine. So maybe low, medium, and high daily dose of each inhaled corticosteroid. They are used like control medication on a regular basis, mostly used in the morning because in healthy person, in healthy persons, glucocorticoids are secreted mostly in the prednisone is secreted mostly in the morning hours. That's why treatment we have to use also in the morning. Non-medication, fluticasone, company name, one of the company name is Flixatid, budesonide, Pulmicort, combined medication of inhaled corticosteroid plus beta-2 agonist, salmeterol plus fluticasone, Seretid, Advair, more new drugs. And after usage of medication, you have to check its effectiveness. There are 4 recommended questions to check asthma symptom control. We have to have well-controlled asthma symptoms. So under medication shouldn't be complaints to frequent attacks and some change of the life. I will list recommended questions. Daytime asthma symptoms more than twice a week? Yes or no? If yes, 1 ball. If no, 0 balls. Any night waking due to asthma? Yes or no? Reliever needed for symptoms more than twice a week? Any activity limitation due to asthma? So if all answers are no, it will be 0. well-controlled asthma. You shouldn't add any medication. You shouldn't increase dose for this patient. You may even try to decrease the dose. If total sum will be 1 or 2 bowels, it means partially controlled. You may continue with the same dose, but you have to follow up patient, and if next time again 1 to 2, you have to change medication or to add the dose. 3 or 4 bowels uncontrolled is daytime symptoms more than twice a week, reliever needs more than twice a week, patient awake due to asthma, and he cannot do his job due to asthma. So in this case, you should add one more group or send patient for additional investigation. Maybe here is not only asthma, maybe it is ACO, and you have to add muscarinic antagonist in this case as fast as possible in higher dose. Maybe patient has some accompanied disease. So in this case, you have to do to manage patient carefully for diagnosis and to change treatment if it is possible. And step 5 approach to control symptoms and minimize future risks in case of asthma. Control medication. In step 1, as needed low dose inhaled corticosteroid formoterol. Only as needed low dose inhaled corticosteroid formoterol. But this combination now is very, very famous and it is recommended very commonly. If rare attacks, inhaled corticosteroid formoterol during attack, if less than once or twice a week, sometimes. If attacks more than twice a week, you have to use regularly low dose inhaled corticosteroid formoterol, and as needed, you may add it so regularly each evening low dose inhaled corticosteroid formoterol. Plus, if during day will be attack, you will give next puff, next inhalation. So the same drug for step 1 and step 2 in regular base or when it is needed or in combination. Step 3 will be combination low dose inhaled corticosteroid plus LABA, or maybe medium dose inhaled corticosteroids. If LABA not good for patient, maybe low dose inhaled corticosteroids plus ligatriene antagonist. Step 4, medium dose inhaled corticosteroid LABA, possible to add tiotropium or to use higher dose inhaled corticosteroid ligatriene antagonist. In step 5, you have to use everything, all drugs which are available, because in this patient, asthma is very severe. Higher dose inhaled corticosteroid LABA, refer for add-on treatment, tiotropium, anti-interleukin E, anti-interleukin 5, anti-interleukin 4, add low dose oral corticosteroid, even oral corticosteroid. So from sometimes usage of inhaled corticosteroid formoterol to combination of inhaled corticosteroid LABA with low, moderate dose and higher dose at the end stage, even oral corticosteroids. Initial treatment for ACO, asthma COPD overlap. For patients with features of asthma, prescribe adequate controlled therapy included inhaled corticosteroid, but not long-acting bronchodilators alone as monotherapy. So for asthma, as I told you, ICS. And if ACO overlap syndrome, preferable symptoms are asthma, mostly attacks, not constant dyspnea present, but not so significant. ICS should be first line, but they shouldn't be alone because it should be combination. For patients with COPD, prescribe appropriate symptomatic treatment with bronchodilators or combination ICS bronchodilator therapy, but not ICS alone as monotherapy. For patients with features of both asthma and COPD, treat with inhaled corticosteroids a low or moderate dose, depending on level of symptoms, add-on treatment with LABA or LAMA, If there are features of asthma, avoid LABA monotherapy. So mostly for patient with ACO, you have to use both, not alone. You have to use ICS, you have to use LABA, and you have to use LAMA. Because this person, as a rule, is more severe, it will be triple therapy. And if patient is uncontrolled, despite your treatment, you have to use to check the diagnosis and referral for specialized investigation. When chronic airway disease is suspected, but syndromic features of both asthma, COPD, and asthma are few, we send patient for specialized investigation. If present diagnostic uncertainty, especially if an alternative diagnosis need to be excluded, we send patient for specialized investigation. Patients with comorbidities that may interfere with the assessment and management of their airways disease. Patient sent it for specialized investigation. Patient with persistent symptoms, exacerbation despite treatment, send it for specialized investigations. Which specialized investigations mostly used to distinguish asthma COPD? It is diffusing capacity of the lung for carbon oxide, DLCO. In asthma, it is normal because no changes in alveoles. In COPD, often reduced. Arterial blood gases. In asthma, it is normal between exacerbation, and in COPD, reduced. Airway hyperresponsiveness. In COPD, less pronounced, in asthma, more higher. We can to use CT scan, obligatory to use X-ray, but if in some special situation which I listed before, we can to use more advanced method for imaging, which is CT scan. In case of asthma, it is usually normal, maybe increased bronchial wall thickening in case of asthma, not always. In case of COPD, low attenuation areas, air trapping or emphysema. Increased bronchial wall thickening may be signs of pulmonary hypertension. Next method, specific immunoglobulin skin prick test. Modesty increases probability of asthma. It is less often in COPD, but does not rule out COPD, especially if patient has overlap syndrome. Fraction concentration of exhaled nitric oxide, phenol. It is high in non-smoking eosinophilic airway inflammation. In case of COPD, it is usually normal. More severe inflammation is in asthma, and fraction concentration of exhaled nitric oxide suggests about more significant inflammation. So in case of COPD, inflammation present but not so active, so it is usually normal. Blood eosinophilia supports eosinophilic asthma, and rare, maybe not typical, but maybe in COPD. So a high eosinophilia is a specific feature present not in all patients with asthma, and usually increase risk of future event, increase risk of progression in case of asthma. Now we discussed all our topics. Thank you for your attention, and goodbye.